Good morning. My name is Mike Bennett. I'm a St Gemma's Professor of Palliative Medicine in Leeds. I work at the University of Leeds, but I also undertake consultant work for 2 days a week at St Gemma's Hospice. My take on Love Your Data is really focused on my research interest, which is pain management. And here we go. So our academic unit is mainly focused on pain research, and we've been undertaking explorations of data based around Leeds and nationally to understand how we intervene better to improve pain outcomes for patients in palliative care. So this is part of an impact programme grant from the NIHR improving the management of pain in advanced cancer, particularly for patients living at home. So firstly, why bother with cancer pain? Well, we know cancer pain is very common. It's quite severe for many. About 45% of patients with cancer will have moderate to severe cancer pain. It remains undertreated despite 25 years of the World Health Organization analgesic ladder. And sadly, for a number of people, it doesn't seem to get better. So cancer pain remains an important symptom management issue. There are a number of barriers for this at all sorts of levels. Patients are often reluctant or can't communicate pain data effectively. They're fearful about the effects of analgesia. Professionals may inadequately assess patients with pain, prescribe poorly, and healthcare systems often prevent access to expert help in Anne's video, the kind of confusion about who to contact, for example, especially out of hours. And healthcare systems don't capture and communicate data on pain. So our work and our trials are all about trying to improve these outcomes. So in terms of some of the areas of work that I'm going to show you some data about, we have 4 programs. One of them is about an integrated system of support, and we're trying to understand care pathways for patients with pain, particularly earlier identification of patients and promoting self-management. We have another work stream that has developed online systems for patients at home to report pain and communicate that with their community nurses and get hopefully a faster response. We've been understanding good management of analgesic drugs through primary care-based interventions, particularly around nurse-led prescribing, and I'll show you some data on nurse prescribing in a minute. And also, can community pharmacists get involved? Can they demonstrate improvements in patient, or can we demonstrate improvements in patient care by closer engagement with community pharmacists? Finally, we've just started a large randomized trial in a number of centres in the UK, testing a number of these interventions. So what I'm going to show you really is some data that has underpinned some of the development of this work, which I think will be interesting. It certainly was illuminating for us and helped us to design our interventions. So the first really is to understand, well, how do people access and for how long palliative care services? We thought this was an important question because if we think that the prevailing zeitgeist is earlier referral to palliative care is related to better outcomes, well, how early is early and what is currently happening? So we obtained data from all 3 Leeds palliative care services, the 2 hospices, St Gemma's and Wheatfields, plus the hospital-based the hospital-based palliative care team in Leeds. We obtained the anonymised data from routinely collected clinical systems, and we had a look at what was the median contact time with palliative care services for patients, for all patients referred. So we collected around, over a couple of year period, we collected around 1,600 patients from each of the hospices. The median interval between referral, first contact with the hospice and death was around 50 days for the hospices. The hospital team, it was a bit short, about half that at 24 days. And because we excluded patients who were counted twice between community and hospital, but of around 5,000 patients in Leeds seen by palliative care services, the median contact time was about 6 weeks, 42 days. Now, the interquartile range of 14 to 119 means that a quarter of all those 5,000 patients were seen for the first time within 2 weeks of their death, and about 3/4 were seen within about 4 months or so. Now, that might surprise you, and I presented this to Ros Taylor once, and she said, no, that cannot be true. It's months and months and months we have patients for. But actually, if you count everybody closely, this is the sort of data we get, and we think this is probably representative of the UK, but we're going to undertake a national survey or national data collection from other units just to see, is this really representative? Because if it is, it means patients are getting referred to palliative care services pretty late, and therefore can we improve outcomes by shifting the contact time by a median of 2 or 3 or 4 weeks possibly, and would that improve outcomes? We're doing more analysis on this data set to understand, is it the timing of the referral that leads to better outcomes? Is it the dose? Is it the number of visits or the intensity of the intervention that might lead to improved outcomes? And we want to understand, to confirm really, is there a dose-response relationship between early or palliative care contact and better outcomes at the end of life? Interestingly, we showed quite wide variation in contact times with palliative care by tumour type or disease type. I'm going to show you on here. So these are different cancers. So gynecological cancers, a median of 80 days referral. Prostate cancers, 90-something days median referral time. But for those patients who don't have a cancer diagnosis, this is COPD, heart failure, perhaps dementia as well. The median contact time is only 20 days, so upper GI doesn't do very well. Hematological cancers, you can just about see here. So quite wide variation. So that gives us, understanding this data, gives us some idea of which kind of patient groups, which clinics or services should we begin to target if we wanted to generate early referrals, or who are the groups of patients with most unmet need. Now, this is a model that will be familiar to you. This probably is about 20 years old, this type of picture. This was the bad old days of the 1960s and 70s when referral was only made to palliative care close to death and only after any life-prolonging or other kind of secondary care treatments had finished. And this was the aspired, or the aspiration was to move to a more integrated palliative care referral. But unfortunately, certainly in Leeds, and I do suspect this is representative of most of the country, but actually I think we are still stuck in this model at the top, really. We've also looked at electronic palliative care coordination systems. So EPACS is the version we have in Leeds. I suspect that close to your homes there will be some other coordination electronic kind of system where in primary care patients are labelled as on the palliative care register, becoming close to death. The idea being that a registration on one of these services highlights the need for palliative care, can improve outcomes, help coordination of care. So we began to look at, could EPACS be a way in of identifying patients with pain problems? Could we improve pain outcomes by intervening on this system? This is too busy for you to read, but this is what the kind of data that we've generated. Firstly, we showed that of all the patients dying of chronic diseases in Leeds over a couple of year period, only around 27%, or just under a third of them, or just over a quarter, are actually recorded on these electronic patient coordination palliative care systems. So a long way to go for patients with chronic diseases who are dying to be flagged up. But what about for those that are recorded on the EPACS systems? Well, we mapped out the timing of different data inputs to the electronic palliative care system and the types of data. The size of the bubble represents the number of patients at that point. Now, what's interesting is that we can see that on average, EPACS records were opened for patients who are dying about 30 days before their death. So that's about 2 weeks after they've been referred to palliative care in Leeds. Interestingly, DNA orders are put on much earlier, and out-of-hours forms around palliative care are put on a lot earlier. And even things like preferred place of death is only recorded a median of 8 days before death. Actual place of death is recorded just after the death. So although this is an potentially important strategy for improving end-of-life care, and it's mentioned in the end-of-life care strategy at a national level, operationally these systems aren't yet working that well, or not to their full potential, it seems. Let's move on to something about medicines prescribing now, and in particular access to strong opioids, which are probably the backbone of good pain management or cancer pain management, particularly at the end of life. We've been tracking all Leeds cancer deaths for a 7-year period, and rather than just taking a cancer diagnosis from a clinical record, we've gone to the cancer registry so that we know that these patients have definitely died of cancer. And we've linked those records with a primary care prescribing database and also to hospital records on all the sort of treatments that they were having and the types of cancer that they had. Of around 14,000 cancer deaths in the last 7 years in Leeds, we managed to match about 6,000 of those with all the other data that we needed. And this is what we found. So we found that just under half of all patients that died of cancer were ever prescribed a strong opioid, which always surprises people, I think, because people assume that palliative care clinicians, all we do is prescribe morphine and we just fill people's boots with strong opioids. But actually, less than half of all people that ever die of cancer get access to a strong opioid, which I think is quite interesting. The most common opioid that was prescribed was morphine, with sort of smatterings of other kind of opioids along here as well. So less than half of people get a strong opioid before they die of cancer. Shows you, I think, some under-treatment in relation to the prevalence and severity of pain in this population. But here's another interesting piece of information. When are opioids prescribed before death for cancer patients? So these are all analgesic groups. This is basic non-steroidals, paracetamol. This is codeine, tramadol, and these are strong opioids. So for all those patients that got a strong opioid, the average or the median was 9 weeks before death. And you can see that the interquartile range here is quite short as well. So some people only getting opioids a couple of weeks before death. 75% of people that get an opioid do it within the last 20 weeks of life. So this idea that palliative care is giving all people with cancer opioids for months and months and months is just simply not true. And I think this helps us to build a picture of under-treatment, poor recognition of pain, and late onset of appropriate management for cancer pain, which I think builds a picture of where we can start to intervene. So this is another sort of demonstration of that data. This is just the cumulative proportion of patients who get a strong opioid. So we tracked data back to 52 weeks before death. And this purple line here is the proportion of patients that were ever prescribed a strong opioid. So at the top here is at the very end of life, 48% of patients have had access to a strong opioid. But at this point here, 6 weeks before death, only 30% of patients have received a strong opioid, of those with cancer. So this is very late onset strong opioid prescribing, and only in half of the population that die of cancer. So a very contracted, small area of prescribing, which I think needs to improve if we're going to improve pain outcomes. And I can tell you from other data that we've looked at that opioid access for non-cancer patients is even worse than this as well. So cancer is said to be the lucky diagnosis, in inverted commas. It's even later and less for patients dying without cancer. Well, interestingly, we found that there was no relationship between opioid prescribing and gender or the type of cancer or even the duration of disease, because you'd think that late onset prescribing might be associated with late diagnosis. But the average diagnosis is made a year before death, and yet opioid initiation is only 9 weeks before death. But worryingly, we found that older patients were less likely to be prescribed a strong opioid. That's over 75 years of age. And patients dying in hospice were twice as likely to get an opioid as those dying in hospital. Or put it another way, hospital deaths, patients dying in hospital were half as likely to get access to a strong opioid in the community than others dying in other places. And could it be, for example, that poor pain control in the community led to hospital admission and a hospital death because of poor access to good community pain management? So, one way of tackling poor prescribing practice, because doctors are rubbish at it, is to look at nurse prescribing or non-medical prescribing. This is a big strategy by the government to improve access to all sorts of drugs, but particularly in palliative care, perhaps better access to end-of-life care drugs and opioids. So we looked at, well, what is happening with non-medical prescribing. We've undertaken some qualitative work around this, but we've also tried to look at what is the impact of non-medical prescribing at the moment. Now, we approached the Health and Social Care Information Centre. They were very helpful, and we devised a methodology with them where we identified all prescribers that had prescribed what we thought were very typical palliative care drugs, so things like subcutaneous midazolam, arsine hydrobromide, levomepromazine. We had a basket of drugs where we identified prescribers of those, and we then looked at their discipline, and we looked at their opioid prescribing on the back of that. We collected data over a 4-year period. This is the kind of the basket of drugs that we looked at for community-based prescriptions. Now, what we can see, so these are the 4 years here. So the number of palliative care prescriptions has risen from about 1.2 million to about 1.6 million in that kind of period. You can see there's been a growth in the medical prescriptions. Interestingly, the number of nurse prescriptions has almost doubled, so there's a lot more activity in terms of non-medical or nurse prescribing. Pharmacist prescribing in palliative care is relatively small, but is growing considerably. So the total amount of non-medical prescribing has gone up, has more than doubled in 4 years. That's fantastic. There's been a lot more non-medical prescribers. But what you can see is that it still represents around about 5% of all prescribing activity. And even though non-medical prescribing activity has doubled, the impact on all palliative care prescribing remains tiny at this point. And if we project this forward at this kind of rate of growth, it's going to be another 20-odd years before there's a substantial impact on non-medical prescribing against all prescribing in palliative care. I want to show you some information now on cost effectiveness or health economics, because one of the languages that commissioners speak, or the only language that commissioners speak, it seems, is cost, and what's the cost benefit of these sorts of things. So there's no point in us designing expensive service models to improve pain outcomes if we can't demonstrate that they're cost effective. So our question was, how much does it cost to the health service to be in severe pain? And what sort of service models do patients want? How do they want their pain management? How would they design pain management services? So we asked 250-odd patients with cancer pain across the north of England. We asked them to do a number of things, looking at quality of life. We tracked all their healthcare resource use. We asked them, using a discrete choice experiment, what aspects of pain management would they prefer over others? And discrete choice experiments are often a forced choice, so patients are forced to choose between two particular types of things. And a good example might be, would you prefer to die in hospital, perhaps with less pain, or would you prefer to die at home but with more pain? An enviable choice, possibly, but that's the sort of choices that we ask patients to make. Now, this is the sort of outcome of this discrete choice experiment. Not surprisingly, the biggest detriment to quality of life and impact on patients is having poor pain control compared to good pain control. So that's a massive detriment to their quality of life if they remain with poor pain control. Interestingly, and often neglected, is actually poor control of side effects is a major problem for patients and impacts greatly. There's some cost out-of-pocket expenses here, But two things that we thought were really important in terms of designing services and talking to commissioners. Firstly, patients would rather, if they can't see a specialist doctor, they'd rather see a specialist nurse. That has less impact, negative impact than seeing their GP or relying on their GP for their pain management. And the second thing that surprised us was actually, over and above seeing a healthcare professional, patients would far rather good information and be told how to manage themselves more than relying on healthcare services. And actually that has a bigger detriment to the quality of life if these things are not in place. Good information, good communication. So what about the costs in terms of healthcare resource use? So these are all patients with cancer, and we split them into no or mild pain, those with moderate pain, and those with severe pain. And the healthcare resource use per month is about 2,500 for those patients with only mild pain. But you can see that for all things other being equal, that living with severe pain costs the health service another £1,500 a month more per patient, just because of increased pain needing increased healthcare resource use. Now, this is getting a bit fanciful, but this is one of the illustrations I've made to the CCGs, that every year in Leeds there are about 1,800 cancer deaths. We know that about 600 will have severe pain, about 600 will have moderate intensity pain. If we just shifted a couple of hundred patients down from the severe category to the moderate category over the last couple of months of their life, we could save every month in Leeds, over that period, about £400,000. If we shifted people from a moderate level of pain to a mild level of pain, just for a couple of hundred of those, out of that 600, we could save another 400,000. So potentially just small shifts in pain, we could be saving £800,000 a year, perhaps, for the CCGs. And that might not sound a lot to the CCGs or to us in terms of healthcare budgets, but actually what it means is that introducing interventions that are well within that cost envelope, in other words, just only cost a few £1,000s or tens of thousands of pounds, and produce these sorts of outcomes, if we can demonstrate that, they're exceptionally cost-effective interventions for being introduced into routine practice. So, what have I learned from all this, and what do I hope to impress upon you? Well, I think understanding data and analysing these sort of bits of data that are either routinely collected or at least synthesised as part of a research project helps us build a bigger picture of what's really happening in our locality and might reveal surprises. Things like short contact time with palliative care services. Fewer than half of all patients who die of cancer get an opioid, and they only get it 9 weeks before death. Those sorts of things are surprising. It identifies opportunities for intervention, I think. So clearly there's an argument for earlier access or more timely interventions, particularly around the area that I'm concerned with, which is pain management. Understanding the cost-effectiveness of service models. And from the health economic data, we know that actually just providing good information and support for patients, rather than trying to put a healthcare professional in front of a patient, may be more valuable. And I think these kind of sorts of data and these sorts of discussions provide common ground for us when we approach commissioners about funding our services or developing new services. Thank you very much for your attention.
Thank you, Mike. 3 really interesting presentations there. I'm sure some of you will have some questions. I don't know if we've got any roving mics, but we've certainly got 2 fixed mics here, so if you want to rove.
Oh, the microphone's a bit tall. My name's Anjali Mullick, and I'm Medical Director at St Peter's Hospice in Bristol, and I just had a question for Anne. Yeah. So in our unit at the moment, I'm hearing a lot that we're struggling to admit patients because of complexity and dependency, but I'm also told that it's too difficult to try and define what that is, and sometimes that makes conversations difficult with our external stakeholders as to why we can't take admissions. So I was just wondering about your tool that you use. What sort of factors do you take into account with the complexity and dependency?
Yes, I'm very happy to share the tool and send you back with a copy. We look at everything from the personal care elements, mobility, risk, communication, nursing needs, also the numbers of symptoms that the patient's presenting with. And having the tool, I think, it gives, we do it in a pre-admission context, so we fill that information out at the time of the admission. What often prevents admissions, we found in the past, was not having the right staffing levels. So what we actually do then is bring the staff in anticipation of that admission. And I'm happy to share it with you.
Great, thank you. And just on a slightly related note, you talked about cross-care a lot, and we're
Yes.
introducing EMIS Web next year in our hospice because it connects up with our local GPs. Do you see the principles of what you're doing transferable across to other electronic systems?
Definitely. As long as you've got a bespoke system that you can influence,
Yeah.
without a doubt.
Thank you very much.
And a question over here.
Hi, I've got two questions, if that's okay. I just need to construct my thinking a little bit. One of them's for Mike. In terms of the differences between nurse prescribing and medical prescribing, there seemed to be a significant increase in medical prescribing on your chart. But one of the things that struck me in clinical practice is that we increasingly are finding GPs are feeling very frustrated and almost threatened by the development of nurse prescribing as a intervention that takes control away from them of their patients and interrupts their way of managing patients. Do you think that there may be barriers that are preventing nurse prescribing taking off in actually operationalising how it's delivered in community settings?
Thank you, Sam. I think there are a number of issues around nurse prescribing. Some facilitative. So there's lots more opportunities for prescribing. I think there's better support for prescribing now. There remain some kind of barriers, really. I think what fundamentally the concept is that nurse prescribing can reduce the time between the need and getting access to a drug for patients. One of the issues already is that for nurse prescribing in the community, they're still using FP10s, and is that a slower process for patients than actually a GP prescribing electronically? So actually, I'd love to do a trial of nurse versus medical prescribing and see who ends up with the quickest kind of drugs. Is it just a good idea but not backed by good outcomes? I think what's clear, the other thing I wanted to add really was that the nurse prescribing, the data that we've got is only probably related to end-of-life drugs, so those last few days of drugs. What we don't know is what the true impact of nurse prescribing is, perhaps on other opioids upstream. And another important aspect of nurse prescribing or other non-medical prescribing, which doesn't get counted in this sort of data, is deprescribing. And actually stopping other drugs is perhaps an important part of a specialist activity. So we can't capture that. So the wider impact, so I've given you one definition of impact, if you like, which is just the number of scripts. But we can't measure accurately the true impact. In terms of the working within the community between medic or GP, community nurse and pharmacist, who I think is a missing part of this important triangle. Clearly better ways or more collaborative ways of working would be helpful, but I don't really have a clear way forward for that at the moment. Yeah.
And my second question was to Katherine around diagnoses. We find that the way that clinical systems allow us to collect data means that we have to use ICD-10. It's how it works within our data collection system. But what I find increasingly within our MDT is that the nuances between what the actual terminal diagnosis is and the diagnosis for which the patient is referred into the service almost become confused. And do you think there are better tools that we should be using for diagnosing the terminal cause of death to improve the data quality, to allow you to do the great work that you're doing?
Thank you. I think it's a really important point. So there are a couple of things potentially from my experience. One is that we can potentially, in the future, make better use of clinical records in order to determine diagnoses. So I didn't really go into detail, but as part of the CRIS database, there is software in it to mine the free text. So when I said these patients had a clinical diagnosis of dementia, that was either because an ICD-10 code had been clicked in a box, or because someone had written in the clinical notes that the patient had dementia. So that is a possibility. The other thing I think that's important to consider is that I said, oh, only 41% of death certificates for people who had dementia had it written on, but actually we wouldn't expect that number to be 100% because remember that the death certificate is only supposed to record conditions which contributed to the death. Conditions that were just by the by and not significant in that death shouldn't be written. And actually, in terms of making mortality data most useful, there is a question there about whether we should be able to record every condition that the patient had when they died, in addition to those which contributed to the death. It's an interesting question, I think.
Thank you. Question over here.
Hello, I'm Dee Trowie. I'm a palliative medicine consultant from Hertfordshire. Everything I've heard today has been very exciting, but I'm aware that sometimes I'm a little bit naive about how I interpret data. So it's a question really for Mike. In one of your later slides, you stated that 2/3 of patients would dying from cancer would have moderate to severe pain. 48% of people on your earlier slide were having strong opioids, which was suitable for moderate to severe pain, but also the weaker opioids can be suitable for mild to moderate pain. So from your two slides, how do we actually know that somebody was getting inadequate pain control? Because with the stats, it could be actually we're doing brilliantly.
We know that a lot of those mild, so a lot of the middle, so the mild kind of analgesics or the weak opioids were kind of low-dose codeine, for example. I mean, I suspect that you don't prescribe low-dose codeine for pain that is kind of moderate to severe. I think strong opioids are a good marker of whether someone's getting, for most moderate to severe pain, that's pain above 5 out of 10 on a scale. I think strong opioids, even low-dose strong opioids, is what we're trying to measure, would be an appropriate intervention for those. What I think is right is that when we've looked at the number of people that are prescribed a strong opioid, there are two things here. We don't know whether those prescriptions were cached, and we don't know whether patients took those prescriptions. And also, frustratingly, we don't have from that data whether that patient or what level of pain that patient had. All we know from meta-analyses of dozens and dozens of trials is good evidence of under-treatment. So there was an update of a review published a few years ago showing that about 30% of patients, and these are tens of thousands in total, about 30% of those have pain scores of 7 or 8, and yet they're not treated effectively with strong opioids. So I think that it's always difficult to generalize from one local data set to a national things, but I think what we can see is that a large number of people have pain and not enough people are probably getting access soon enough. Bear in mind, at cancer diagnosis, the commonest indication to take a person to their doctor or hospital where their cancer is ultimately diagnosed is pain. So pain exists for probably a year on and off for that person's life, and yet it seems that they're only getting adequate treatment in the last kind of few weeks or the last couple of months.
Can I just chip in as well that the most complex patients who come to my clinic with pain actually have neuropathic pain which hasn't responded to opioids? So do you think there's a risk that focusing on opioids and increasing the prescription of that is actually missing the needs of our patients when actually they need some gabapentin instead?
Well, I would have loved to have shown you a meta-analysis that we've just completed on the addition of adjuvants to opioids versus opioids alone for neuropathic cancer pain, and it shows no difference, no added value, but increase in side effects. So this is a discussion for another time about clinical prescribing, but I think opioids remain the cornerstone of all pain management, however inadequate they may be, and we need better drugs, but actually I think opioids are still good for most pains.
Thank you.
Thanks.
Thank you. Oh, another one over here. Another question.
I'm Brendan Amesbury from Chichester. I was very pleased, Mike, to see that your median time on caseload is the same as ours. I'm also terrified that it's only 42 days or 45 for us. It used to be about 90 days some years ago, and we want people to be referred earlier, but they're getting referred later. We've also noticed that the number of people referred by GP is dropping massively, and it's now only 20% or 28% of referrals to the hospice. I suspect the two are linked. Do you know what percentage get referred by GPs in Leeds?
Well, if I don't, although I know that about 2/3 to 3/4 of our overall referrals come through the community rather than a hospital route. But actually, the number of referrers now, so community matrons, district nurses, other kind of CNSs, so heart failure nurse specialists. So actually, there's a broader range of prescribers, and what we don't know is where the GP is in all this, whether they've given authority and approval, whether they've initiated it, but actually someone else has done the paperwork. I think that's the bit that remains unknown to me, really.
I think a large number of ours come from the acute trust, and that may reflect the work we do in the acute trust, or it may reflect other factors. I would encourage people to come to a discussion about self-referrals. I'm doing this afternoon. We have about 40 self-referrals a year, which is, some of them come from hospital, which is a shocking thing, really.
Well, I think, Brendan, just before you go, I think an important bit about this, we all sort of bang on about early referral, and the Temmel paper suggested about, actually the median time in those American studies is about a year or 8 months before death. Now, is that cost effective? Can there's got to be a point, where is the point of optimum cost effectiveness for a referral to palliative care? It's probably earlier than 6 weeks, but it's probably not 8 months either, I suspect, for thousands of people. So it's that bit of where we need to work that out a bit as well, really.
Thank you for that. And one more over here.
Thank you very much. My name is Andrew Thorns from Pilgrim's Hospice in Kent. I love the idea of using our data better. Increasingly, we're using patient-reported outcome measures. So how far away are we from all hospice units sharing their patient-reported outcome measures to get better data on the symptom prevalences that we come across?
Well, I think we probably are quite a long way, because I think, certainly from the informatics system in the southwest, we're starting to build up pictures in terms of outcomes that are perhaps more detrimental. But I think we've got a lot of work to do in that field. I mean, I think perhaps some of the work with the echo that we heard this morning would be a good starting point to actually pull people together to have those discussions, really. Don't know.
I think
So many different types,
project is probably the most, the biggest ticket in town at the moment, however imperfect some of those might be, but certainly objective measures are one thing, and the patient-reported measures is probably going to be important. For how long we can collect patient data up until the point of death is an issue, and how well those are going to be implemented or integrated. But that seems to be the common language that we're going to be using over the next few years, I think.
So it's a shame that Phyllis Murta isn't here today, because I'm sure she would have liked to have tried to answer that question. I think that patient-reported outcome measures collected routinely are a really important part of the future. I can't answer your question about when that might be, but we do know that it works in Australia. So there is a model where they do collect patient-reported outcome measures, and they share within hospices and learn from each other. So I think we have something to aim for, but I don't know how long it will be.
Thank you for that. I think it is about the maturity of our systems and processes, and I don't think we are, certainly in the Northwest, we're nowhere near that. I think we still live in silos when it comes down to the collection of data, and that is a shame, really. One more question.
Partly a question, partly a comment. We're one of the pilot sites for the PHE individualised data collection, and one of the things that we're very conscious of, and I think the other pilot sites that I'm aware of are well, certainly at St Luke's we're aware of the value that collecting that data brings. What I don't think we've had is a debate within the hospice sector about the importance of actually collecting these measures. And I think it's partly because we don't understand how we can utilise them, both to promote the role and the value of hospices and to improve our services for the patient. And I think, as a unit, that kind of comes on to my question a little bit, in that this has been a wonderful session on data collection and how you can use it. But as a medical director in a unit, what I would love to be able to think is these are the metrics that I should be trying to draw out of my data collection, given that in our unit we do use some of the OAK measures, we do have admissions data, we do have prescribing data, we do have death data, all checked in our MDT. but actually we don't have the kind of metrics that say that this is what we should be collecting in order to benchmark or to contribute to the sorts of studies that you're doing. So how do we start that process? How do we enable us as hospices to access your knowledge and expertise in your work to enhance the data that you've collected in these national projects? And that's something that we should be galvanising through Hospice UK, for example.
I mean, I think that you've sort of hit the nail on the head, but I think the answer is that it's a work in progress. And part of the research at the Cicely Saunders Institute, the Oak and the Sea Change studies, are looking at exactly that question. How can we actually, what is the best way to implement these measures, and how can we use them to best effect? So I think we will try and have answers to that, but I don't think we have answers yet.
Well, I think... either the panel want to comment? No, I think that's a great place to finish. We've had 3 brilliant presentations there. I think I would sum them up in terms of one being at the organisational level, Anne's presentation about what's going on, so Margaret's, and I love the phrase data paralysis, because I think that's what we all suffer from. It's about solving the problem rather than collating the data, thinking about what the problem is, and this holy grail of the dashboard that many hospices have been trying to work towards, and I'm sure there's some more coordination could be done in that area. I'll certainly be talking to Anne about the template that they developed there. And then Catherine's presentation was at the macro level, to recognise and understand the limitations that could have that we have in the data, and actually linking sources of routine data together to get a wide and deep picture. And I think being careful that we don't make assumptions about the data that we collect. And then Mike's presentation at a clinical and locality level, I think, about the challenges of collecting data around pain. Some of those statistics about less than half of people dying with cancer, getting access to opioids, amazing statistic. And this tension between the efficacy and quality of care and cost effectiveness is always there. But I do like the idea of the cost effectiveness around the shifting of patients down the scale of pain. I think that is something that we could all use in our conversations that we're having with our commissioners. So a great session. I'd like you just to thank our contributors in the usual way. Thank you very much indeed.